Hello and welcome to Level 5 Health and Social Care. We are now starting on Unit 504, our fourth unit, and that unit is about partnership working. So this is week 1, and at the beginning of week 1 we're going to look at the philosophy of partnership working and some of the barriers to partnership working. So let's look at our two objectives, which will be from task 1. Okay, the two criteria task 1 is about is 1.1, which is explain the philosophy behind working in partnership, and 1.2, which is explain the potential barriers to working in partnership. Okay, let's start with a couple of definitions. What do we mean by philosophy? Philosophy, it's the state of mind or consciousness that influences the belief, values, and behaviours of the people. So that's a sort of general, all-encompassing definition of philosophy. Here, we're going to focus on the sort of ideas behind partnership working. And partnership, a definition of partnership, as provided by SCI, the Social Care Institute for Excellence, is the essence of partnership is sharing. It's marked by respect for one another, role divisions, that's being, people being very clear about who does what your job is, rights to information, bearing in mind that people have a right to know things so they can carry on and do their job properly, accountability, taking responsibility for what you do, competence, being able to do your job properly, having the skills to do your job properly, and value according to individual input. So that's your actual input being valued and recognised. People sort of saying you did a good job there, so you know that you've been appreciated. In short, each partner is seen as having something to contribute. Power is shared, decisions are made jointly, and roles are not only respected but also backed by legal and moral rights as well. So there's a legal requirement for people to be respected, and we know that's picked up in legislation like diversity, equalities legislation, that actually support people from being denigrated because of their sex or their sexual orientation or their colour or their creed. Okay. So what is partnership philosophy, really? It's basically a mindset. It's an idea that there is benefit in communication and collaboration. Now, you may notice that I've highlighted some words here, and they are the important words for you to remember when you're writing your response, your paragraph around this area, this week's work. Okay, so try to keep those words in mind when you're doing your write-up. Okay, and those are the words that I want you to expand upon in your descriptions and your evaluations. So communication and collaboration, really, really important. This partnership philosophy strongly emphasises that in successful collaboration, every member must demonstrate responsibility towards the team. So that's taking responsibility to what you do, and what you do as part of your team. So those of you who are working in care homes, thinking to yourself, it's not just my responsibility to turn up, do my job and go home. It's my responsibility to work as a team member, support the rest of my team, don't leave things for them to do when I should have done it. Don't do things that's going to make it difficult for them when they come on shift later, those sorts of things. So as such, individual members must be empowered. So you must be empowered by your manager, by the organisation that you work for, to be able to carry out your job properly. So there's no point you being told that you've got to do this and then find out that when you go to work there's restrictions on you do that because you're like a junior member or something like that. That's not really helping. or that you don't ever get the chance to learn the skills to do what they ask you to do. There's no point asking them to help, I don't know, to get you to teach a client how to look after their health if you don't already have the skills in the first place. So that in that relation, if they want you to do that, then the organization has responsibility to train you correctly about, say, safeguarding or about, such things. So as well as being empowered, they need information to make informed choices. So you as a member of the team need all the information available to make an informed choice. So the team can't go forward with a treatment decision if they don't have all the information. And that works for the client as well. The client can't agree, shouldn't be made to agree to something if they don't have all the information they can to help with proper decision making. We've talked about this before in your level 3s and 4s. Empowerment for staff, empowerment for clients. It's been a sort of the underbed of everything that we've been really talking about. Role distinctions, as I said, although people can cover each other, you're thinking about multidisciplinary teams. We've talked about those at level 3 and 4 too. But people do need role distinctions as well. You do need to know when you come on shift what you are responsible for today. And, that you can't assume that someone's always going to do the bits that you're responsible for. So people need their own distinct, what have I got to do today? Personal identity is, who am I? I am a nurse, I am a carer, I am a social worker. You need to know what that role means. Independence and autonomy to perform effectively. Again, this is something that needs to be given to you by your manager and the organization you work for. But also you need to be given the skills to do it too. So you should be able to make some independent decisions to the level of your role, and that should be in your job description, in the competencies that are required of you before you start your job. And you should be given the autonomy to make those decisions up to the level of, whatever job you're employed for. So obviously, the manager of your care home has a heck of a lot more autonomy than a care worker does, because the manager has a huge amount more responsibilities. Well, they're different responsibilities, really. So there needs to be fair and transparent policies, nice and clear, easy to read, easy to understand, so that people are not confused about what they're supposed to do. And there needs to be power sharing where it's appropriate. Okay. Power sharing it to enable you to do that job. So you don't have to be saying you're working with Mrs. Jones, and you're working on making her choices about what she wants to do today, what she wants to eat today, what she wants to wear today. You're not going to be running to your manager or your supervisor every 5 minutes saying, we've talked about this, is this okay? You need to have been given the power to sort of say, yes, Mrs. Jones, we will get that dress. Yes, Mrs. Jones, we can help you make a cake today if that's what you feel like doing, all those sorts of things. So as really important part of this philosophy of working in partnership, especially where you've got people from lots of different backgrounds. So thinking about your multidisciplinary teams, where you might have a consultant as part of your team, you might have a psychologist as part of your team, and then you might have nurses and you might have care workers who maybe aren't as highly qualified as some of the other people. But the important thing is that every member of the team has the same level of respect from the rest of the team. And also, when you're working closely with clients and their families, that level of respect goes out to them as well. And it's not, because I'm the skilled person, I know more than you do, so therefore my idea of the decision is better than yours. You need to respect their views as well. Okay, so this important of respect goes, as I said, it's a two-way thing. It's given to the receiver of the information and the giver of the information, and it's really important that everyone who's involved will be highly valued. Okay, so as I said, just because you're the care worker and the consultants in the team, your opinion should be as highly valued as his or hers. So we use the term partnership working fairly loosely, but different organisations use different terms that mean the same sort of thing. So you might not hear it always being called partnership working. It can be called things like shared learning. It can be just called simply cooperation, working in cooperation with each other. It could be collaboration. So listen out for some of these words. It could just be known as teamwork. And on a day-to-day basis, when people are employed together, it's often more often than not called teamwork rather than a partnership working. A partnership working can often be quite a formal process where two different organisations are working together. Um, it can be called joint practice or joint education, where you work with somebody from another team. It could be, well, things that we know about from our level 3 and 4, interdisciplinary partnership working or multidisciplinary working. Okay, so your MDT team is partnership working. It could just be known as participation, particularly when you're involved in sort of families, carers, friends, the service user. You might just be talking about user participation. You might talk about family participation, advocates participation, but you're still working in partnership. So remember that all these words are other words for working in partnership. So why is it important to have this philosophy of partnership? What's the value to it for you? So successful joint working is a vital component, and some of the objectives that we have for doing partnership working is to streamline assessments, prevent families from having to give the same information to multiple professionals, something families complain about all the time when they do have to do it, or the service user complains about. To improve information sharing between professionals, to improve the efficiency of the care system as a whole. So things get done quicker, things get done in a smoother way if there's partnership working. To coordinate the provision of care so people know who's doing what and when, because we're talking to each other all the time. And to improve the planning and commissioning of care so that things actually complement each other rather than disrupt each other. So instead of the service user having 5 different people come at the same time to see them and do different things with them, like their physiotherapy or their medical examination, you can coordinate things a little better so they don't get overloaded and they can spread things out, and the service user gets a bit of peace and quiet as well. So that's really important. These are generally the objectives of partnership working. They're some of the biggest ones. What I'd like you to do is I've got some resources for you to read that have accompanied this PowerPoint. And if you have a look at those, you'll be able to pick up some other objectives as well, okay? Because that's not all of them. These are just some of the sort of the most commonly thought of ones, really, the ones that come to mind quite quickly. So please do read that, so to give you some other examples to write about. Okay. So let's have a look. What sort of types of joint working are there, especially in the UK in health and social care? So multidisciplinary services or teams, which are often a mixture of health and social care provisions, such as community mental health teams or child and adolescent mental health services. There could be older people services. It could be safeguarding teams. Also, the joint commissioning of services by local authorities and primary care trusts. And this is a bit of a newer thing, really, where health and social services actually get together and decide, and they might even pool some money as to what service do we need? Where are the gaps in the services? What can we do? Should we have a specialist team to do to this, to work with people with chronic obstructive airways in the community, say, for example. What sort of people do we need? You'd need health staff like physios, but you would need social workers and occupational therapists as well to think about whether you need to adapt a building or, give them, get them equipment, help them walk a bit easier, arrange for mobility cars, those sorts of things, and then come in and do their physio or do their lung, district nurses to do their peak flow lung tests. So they all work together, telling each other, observing whether there's improvement or whether something goes up or down, really. Leading off from that, joint working became pooled budgets where we did so much maybe joint working that some of the budgets began to be pooled. And that was a little bit more complicated, I can assure you, because I was around when pool budgets started happening. And so there were some nightmares attached to it to do with legalities and, getting once you get the lawyers involved, everything takes a lot longer. But, for certain services we had, there were pool budgets. Some of my services, because my services were adult disabilities, there was quite a mixture of health and social care, physical, for people with physical disabilities and learning disabilities. So we actually had to manage a budget that was part of it was pooled. Some of my money came from the NHS, some of my money came from social services. Structural integration of organisations, that's creation of care trusts to provide, or commissioning health and social care service, or the establishment of joint management teams to run councils. And again, a lot of these were filled with legal nightmares, but they were developed, really, as I said. So some of my staff were funded and had supervisory management at NHS, and some of them social care. That was, I had a lot of management nightmares, really, working across the two of them in relation to actually managing people. So, but hopefully the service users didn't really feel that. And there are things set up, strategic partnerships, which are set up in law, such as safeguarding children and also safeguarding adult boards as well, where you have partnerships from health, the police, social services, various advocacy teams and things like that. They're quite long and complicated, but they actually do some very good work. Those are some of the more formal, I suppose, bigger areas of joint working. Multidisciplinary teams, we've talked about quite a lot over the last year. So you're aware of those, but also just within your own organisation, within the care home structure that you've got, you might have outreach workers, you might have day services, all sorts of things. So there is joint working on a smaller scale, maybe a less formal scale, without the need for all the lawyers that I had. Just working across your teams, you working with the kitchen staff to make sure that people had food when they wanted it. You working with some of the day services or activity staff to make sure that Mrs. Jones got her painting activity, those sorts of things like that. Okay, so that's a little bit about the philosophy. Like I said, I would like you to read the resources that I've attached for you so that you can expand and give me some wider examples as well, rather than just doing the stuff that I've told you. So let's have a think about barriers. We can probably imagine what some of the barriers when we talked about multidisciplinary teams, as I said, in level 3 and 4, we talked about barriers then. So if you want to look back at that, some of those barriers still come forward, but I'm just going to highlight a few here. So what are some of the known problems with partnership working? Again, going back to some of these bigger partnerships that I just mentioned, that are actually covered by legal issues as well. Well, as I said, as soon as you get lawyers involved, you've got a problem there anyway. So although a lot of people verbally believed in joint working, there were some difficulties. Delayed discharges from hospital, mainly of older people. These involve cases where a patient can't leave hospital. So there was supposed to be some joint working between health in the hospital. So Mrs. Jones came in, after had to have a hip operation, and had to go back to her care home or to her own home, but that she would need a package of care in place. And the problem would be that the Mrs. Jones was ready to leave hospital, and maybe the package of care wasn't in place because social services couldn't get the staff to cover it, or there was just some paperwork that hadn't been done. You might have been at the other end of this in your care home, or other things might have not been put in, or transport hasn't been put in place. Yada yada. Also, we have to acknowledge over the last 14 years, cuts come every year to the NHS. Money savings. So we've had austerity budgets for quite a long time now, and the NHS cuts have been very often to the continuing healthcare rather than the acute healthcare. So they don't stop someone giving you, dealing with a cardiac arrest, but it's more the sort of slightly longer, more complex things that happen when people move out at home. That's where some of the cuts have come in. And this has led to all sorts of terrible arguments between the NHS and social care professionals. So NHS have withdrawn some things that NHS used to fund, they now no longer fund, which meant that social carers had to pick up the funding. And of course, they've had cuts as well. So you end up having lots of, to put it nicely, fights over who's paying for what, which sometimes delays the chance for someone to get the service because it's got to be signed off and agreed. And if you go into arguments about it, it usually has to go up the chain for a higher decision. And of course, that takes longer, and the poor old person's waiting at home with nothing. The breakup of community health teams, because of the cost pressures again, so some social care stuff where we had integrated teams, like I had an integrated mental health team. Some councils have withdrawn their social workers from mental health teams because they don't agree with some of the philosophies, and the trusts have been considered to be a bit unreliable in certain areas around safeguarding, whereas social services believes that they follow the safeguarding legislation quite well. They believe that sometimes the hospitals haven't followed it and there have been issues. And also personalisation. You'll find that often social care services are a lot higher ahead with personalisation than, say, hospital services are. And that's sort of created some divisions. So you might find that the teams are broken up because the social care team are getting fed up being sort of damned with criticism that actually belongs to the NHS and not them. So some people are actually separating them now. So that's been a problem, really. It's breaking up this partnership working because they can't agree on a way forward. Again, a lack of NHS engagement in child protection. They tend to sort of put that onto social services and, say nothing to do with me. And a lack of coordination for children's services in itself, which are always very difficult, always fraught with a lot of problems, and always very, very quick to be condemned in the newspapers, as you can imagine. So again, where you can't control what a member of your team's doing, you find that both NHS and social care have been reverting to type, sort of saying, well, we manage the social care staff so we can make them do what we want. We can't make those nurses from the NHS side do it. So it gets very complicated with the management. So in the end, people say, well, we're just going to look after the people that we're funded to. Pool budgets have been quite complex. They've had lots of money spent on them because of the legal issues about transferring monies here and there. And research has shown that unfortunately, outcomes haven't really improved that much or any better than when the two different departments were managing their own budgets. So we're still looking for improved outcomes there. Logically, there should be, but a lot of money has been spent on it without a great outcome. Formal partnerships, as I said, have been scrapped mainly because of the partners have disagreed on how to go about things. Safeguarding is one of the big issues that both social services and the NHS have disagreed on, or not really acted on in the same way is probably the best. And because of that, it's broken up formal partnerships. But there have been others as well where the two different authorities have a different philosophy in how to approach things. So there are negative issues to think about. More generally, those barriers are very specific. They're things that we know has happened, but there are also general barriers in working with partnership. Because health and social care agencies often have different government performance regimes, they have different targets to meet, which sort of pulls them in different directions. So they're working together as a team, but 3 of the team have got to meet this performance target. 4 of the team have got to meet that performance target. And they might not be the same performance. So, like, what do we focus on? What, they're trying to juggle 2 priorities at the same time, and they're both getting earache from from above. You can imagine that's quite difficult. Just stupid things like health and social care using different IT systems. It's taken, they started about 30 years ago trying to bring the IT systems together across local authorities and local NHS. And as far as I know, they haven't achieved it yet. And it's just, again, there's so much legality involved and legislation and different legislation on health as there is to social care about IT sharing. Much more security is expected in health, and it's become to a point where they can't even raise that security for someone in the same team. Well, they can, but it's very complicated. And then there's just the argument about, well, I spent millions of pounds on this IT system. Why do we have to get rid of mine, and why do we keep yours? And honestly, they're still going on. Cuts in one budget create demand pressures in the other. So again, as I said, when the NHS have had very strong cuts on them, it will put pressures onto the other budget. And it could be the same that, one funding year, social services have huge cuts on it, and that will try and put pressure back onto maybe somebody else's budget. Health and social care staff on different terms and conditions in integrated teams is a real problem. So, things like they get more holiday, they get paid more for doing the same amount of hours. It's you sort of know about it, but when you're actually working together in an integrated team and you're all sort of doing the similar work, you know about it even more, and people start resenting it and complaining about it. And it causes problems within the team. So think about that as another possible barrier. And there are other barriers that come up. And again, if you look at the resources I've put up for you, there'll be lots of other ideas for barriers to think of as well. So that's pretty much it for this week. But I want you to read those 3 resources that I've attached, and that will enable you to sort of make some notes and pick up some quite nice examples for task 1. And remember, if you're bringing something out of one of the free resources I've attached, please don't forget to reference it correctly. And also, I just for your own sort of enlightenment, really, I'd like you to watch this YouTube that I've put the link for you there. Why partnership is at the core of effective healthcare. And this is a TED talk about the patient experience, because a lot of the stuff I've talked to you about is about staff and working with staff. But we do need to don't forget that the patient is a partner, patient or the service user, whatever you're choosing to call them, depending on you know, what discipline you are. And this is quite a nice TED talk about a lady who thought she was going to die but didn't, and then how it galvanized her into encouraging the patient experience and patient partnership. Really, people having more say. So don't forget when you do your write up about the service user. A large part of this will be about different organisations, but you know, don't forget the service user is always a partner. And I think you just find this sort of quite inspiring to listen to. It's quite interesting, anyway. Okay, so that's it for week one. Any questions that come up, you know the drill. Just WhatsApp me, and I'll answer any questions that I can for you. Okay, I look forward to seeing you for week two. Thank you. Goodbye.